clinic, and today we start our bedside session on history taking, and we will have a series of videos on this topic, elaborating each components of history. As you know, history taking and physical examination is the backbone of medicine. All medical students and all of the doctors in this career should be equipped with the skill of history taking and physical examination. So one of the most important things that we should know is history and physical examination helps us to reach about 80% of our diagnosis. So it is very important on reaching diagnosis and on patient treatment. During my clinical year attachment, there was a Professor Yo, who was a pulmonologist at Jimma Medical Center, and he said history is a story. It is the same as like during our childhood we read storybooks. For example, Snow White and the Seven Dwarfs, or The Beauty and the Beast. In these storylines, you will get some characters. For example, Snow White is one character, the Seven Dwarfs are another character, that evil woman or that evil queen is another character, her father, the king, is another character. In the patient history, we may not get these characters. Rather, the characters are the host or the patient. The host of the disease, the patient, is one character. The disease itself is another character. That disease can be infectious, like from bacteria, virus, fungus, or parasite, or it can be non-infectious, different hormonal disorders, metabolic disorders, and the like. So the disease entity is another character. And the other thing is the environment. There are different aspects of environment, whether it's natural or human-made, and different social and personal aspects of the patient's surrounding. So it is an interplay, or these characters will play together in order to make the patient history. So we need to dig the patient history from starting to the end, considering like a story, what happened from the beginning to the end. So at the end of our skillful history taking, we will get, or we can reach on, the patient diagnosis. So it is very important to know this point. The other thing is, we can also take another analogy, the significance of taking patient history. For example, as a medical personnel, you may go to some tertiary hospital and you may not know where the laboratory is. So you will ask someone in the surrounding who may be a medical doctor, a nurse, a janitor, or he can be a security guard, and you will ask him where the laboratory of the hospital is. So that person will tell you on which way to go to the hospital, on which floor it is found, on which block it is found, on which way to turn, and on how to reach to the laboratory. At the end of a clear description of the path of the laboratory, if it is clear, if it is appropriate, you can reach to the laboratory. If it is not, you may miss the laboratory. It is the same as that. Appropriate history taking, if you take the patient history appropriately, you can reach to the diagnosis, which means you can reach to the laboratory. If it's not appropriate and if it's not clear, you may not reach to the diagnosis or the assessment. So for that reason, history taking is by itself, it needs a skill, it needs knowledge, and it needs cooperativeness of the patient and dedication of the physician. So if we say this much about history taking, now we can proceed to the components of history and how to take history. I hope you understand the basic purpose of patient history taking, and now we will proceed on basic things that we should know while taking a patient history. As I have mentioned earlier, always we should know in which department we are evaluating the patients while taking history. This is because in general, the backbone or the skeleton of history taking is the same in all of the departments, but we may need a special focus or additional points or additional examination skills might be involved in specific additional departments. For example, history, there might be slight modifications or additional points while taking pediatrics history. Or if you are in psychiatric ward, you may need additional points that you need to focus or to elaborate. If you are in OBGYN department, or if you are in other, for example, ophthalmology department, there are additional points that we need to focus while taking our history. So always, as much as possible, we should know in which area the patient is complaining while taking the history. So based on this, there are two types of assessment, patient assessment. The first one is comprehensive assessment, the second one is focused assessment. So when we are taking patient history, if it is comprehensive assessment, it is used when we evaluate the patient for the first time. That means if we don't know the patient at all, or if we don't know, if we never evaluated him before, so we have to explore each and every aspects of the components of the history. This is specially advised for all medical students should take comprehensive history as if they don't know the patient before, or as if they didn't see the card, or as if they didn't evaluate the patient before. So they should take the details of they should involve each and every components of the history in their assessment. So that is what we call it comprehensive assessment. Comprehensive assessment is also used by medical doctors. If they get that patient for the first time, it should be comprehensive assessment. This is because it will be a baseline for the next time evaluation. We may not need to ask each and every component of the history each time we write the progress of the patient, or if we evaluate him every 2 or 3 days, we may not need to ask each and every component of the history because we have the baseline comprehensive assessment. So this is the main purpose of comprehensive assessment on history. The second one is focused assessment. It is not advised for medical students, but as a physician, medical doctors can use this focused assessment, especially when we write the progress of the patient. We already have a comprehensive evaluation before, so we know the patient well, so our current history taking will be a focused one. It may focus on the improvement of the symptoms, or the presence of any additional symptoms, and in general the general improvement or deterioration of the patient. So this is what we call it focused assessment. So this is what is our plan. So we should know whether to take comprehensive assessment or focused assessment. As I have mentioned, for medical students, it should be comprehensive assessment. So the next thing is, if we know or if we decide on these points, we will directly proceed with components of patient history. So generally, we will outline the whole components, and in each topic we will elaborate why do we want to ask those questions or to include on the patient history. So in general, the backbone or the skeleton of history starts with one, identification of the patient. It has also its own components. There are points that we should include on the identification of the patient. The next one is, if there is any previous admission, should be elaborated, especially if that previous admission is not related with the current complaint. We can elaborate and discuss under the previous admission of the patient. The next thing is the most important component of history, that's the chief complaint. The third one is the chief complaint. The chief complaint is the one which helps us to decide on which areas to focus, on which symptoms to focus. It will also help us to outline our differential diagnosis for the patient. So considering those differential diagnoses, we can reach to the diagnosis. So our focus of the history, the path of the history, the area that we are going to focus will be decided by this chief complaint. So always we need to be cautiously and carefully ask the patient the chief complaint. If we miss the chief complaint, it may mislead us to wrong diagnosis or additionally, it helps us. It makes things difficult while listing also differential diagnosis. So almost the path of the history is determined here. If you miss this way, then you will be on the wrong path or on the wrong road. So you may not reach to the final assessment. So the chief complaint is the most important, and the most important symptoms that the patient takes him to seek medical attention. The main reason why he came to the hospital is the chief complaint. So based on that, you can develop your history. So this is the third component of the history. And the fourth one is history of present illness, HPI. So you will elaborate the chief complaint, you will explain, you will explain about the risk factors, you will explain about the complication if the patient develops. You will also assess the differential diagnosis that you have considered under this history of present illness. Anything which is relevant to you or anything which is related to the chief complaint should be included in the history of present illness. And the fifth component is past medical, surgical illnesses. So under this part, there are pointers that we are going to discuss on the future videos, and it is important to assess if the patient has any previous medical or surgical conditions. If it is related with the current complaint, we will take this component of the history to the history of present illness. If it's unrelated, simply we will mention them under the past medical and surgical illnesses. So after assessing this part, we will proceed with family, social, and personal history of the patient. As we know, different aspects of there are different family diseases, so we can assess we can reach to the diagnosis by assessing the family, the presence of those illnesses within the family. So we may consider them in our differential diagnosis. Personal history from childhood to the up to now should be explored, because we may explore different risk factors, because different personal habits are directly or indirectly related with different diseases. For that reason, we need to explore those personal histories and family and social history. And at the end of our history, we need to assess a review of systems. Review of system is reviewing if the patient has any complaint starting from the head to toe. So we will go down starting from the head. If the patient has any complaint, if he has any complaint in his head, if he has any complaint on his eyes, nose and throat, on his ears, neck, we will go down to the tip of his toe. And this helps us to assess if there is any missed symptoms. Sometimes patients consider some of their symptoms are unrelated with the current complaint. For that reason, they may not tell us, and we may reveal or we may get that symptoms while reviewing each systems of the patient. So for that reason, review of system is the last thing that we need to explore and assess by the end of our history taking.